payers and providers basic information on vaccines and issues surrounding this vulnerable group. Please note, this forum does not provide medical advice, but is an overview of issues surrounding vaccine and cancer patients, and will be limited by the evolving updates in the scientific literature. We will be having 6 speakers who are experts in their field to share their knowledge and ideas or experience on this controversial issue. To officiate the event, it is a great honor that we invite upon the most dedicated person who has tremendous effort to make this public forum happen for the benefit for all of us, especially for the cancer patients. Please join us in welcoming Mr. Wong Kwan Seng, who is a president Together Against Cancer and President Prostate Cancer Society Malaysia, and also the Vice President of Persatuan Guanglin Chikong Malaysia with 10,000 cancer members. To grace us with his welcoming and opening speech. Without further ado, please welcome Mr. Wong.
Okay, sorry, I didn't. Okay, I now just managed to unmute myself. Thank you very much, Dr. Sonisa, Prof. Dato, Dr. Professor Adiba, Prof. Dr. Noor Aisha, Prof. Dr. Ganjinjin, Prof. Dr. Saguna, distinguished speakers, fellow. Can you unmute yourself when you come in? Fellow survivors, cancer survivors. TAC webinar forum with collaboration with Prostate Cancer Society and TAC. I mean, Prostate Cancer Society, TAC, Hospice Malaysia, and Hospice Malaysia. Now, this is held, of course, in conjunction with the World Cancer Day celebration. Now, we are extremely fortunate today that we have the resources to get a panel of top experts who can look into the COVID-19 pandemic in Malaysia to give a good assessment of the COVID-19 vaccination. We'd like to thank Prof. Dr. Noor Aisha, which is also a vice president of TAC, and her team for working tirelessly and meticulously to bring the forum today a success. I just noticed that, in fact, in our Zoom, which we subscribed for 500, is already full house. So we are, as for yesterday, we have 700 plus registered participants. Perhaps some of them are going to video and others other means, YouTube lah, video to YouTube, which is live. And it will be a tremendous success. It's a record, okay? And I would like to, I'm speaking, of course, on behalf of TAC, that's Together Against Cancer and Prostate Cancer, which I lead both groups. And I would like to encourage everyone, especially Prostate Cancer Society members and Together Against Cancer members who attended this meeting, to dispel all your doubts about vaccination and get over all the disinformation and fake news. Now, millions have been vaccinated. It is safe, okay? So on the other hand, you must realize, we as cancer patients, especially those like me, who have other comorbidities as well, and are also in advanced age, 60 or 70 plus, and some of us, our members, have even 80 plus. We won't get a second chance if we get COVID-19. So this is very serious, you know. And don't worry about the safety. I mean, we benefit much more than the risk that we are going to take, okay? Okay, with that, I'd like to wish you all to have an enjoyable and informed meeting. And this morning, and after the talk, I would hope that all of you would have the confidence to get the shot. Okay, thank you very much.
Thank you very much, Mr. Wong, for such inspiring speech. We hope this public forum highlight and enlightening the knowledge on COVID-19 vaccine in cancer patients. As Malay proverb always said, tak kenal maka tak cinta. Let us get to know our moderator and all our 6 speakers for today, starting from our moderator, who is Prof. Nur Aisyah Muhammad Taib, who has brought all the speakers together and leads the way to ensure that this public forum to happen. She is no stranger to the surgical fraternity, whose work and contribution have expanded the field of breast surgery over the years. Prof. Nur Aisyah is a senior consultant breast surgeon, Department of Surgery Malaysia. Prof. Nur Aisyah expertise are deep knowledge of cancer health system in Malaysia and breast cancer survivorship. She is a principal investigator for a few studies, namely Malaysian breast cancer survivorship cohort study, which have been published many publications under the studies. She has been appointed as the director of the University of Malaya Cancer Research Institute 2019 until present to enhance collaboration and impactful cancer research in University Malaya. Then our next speaker is who is well known to us as our former Dean of Faculty of Medicine, Prof. Datuk Dr. Adiba Kamaruzaman. She is a senior consultant, Division of Infectious Disease, Department of Medicine, University Malaya. Professor Adiba Kamaruzaman graduated from Monash University in 1987 and trained in internal medicine and infectious disease at the Monash Medical Centre and Fairfield Infectious Disease Hospital, Melbourne, Australia. She is an adjunct associate professor at Yale University, USA. She established the Center of Excellence for Research on AIDS, CHERIA, that conducts multidisciplinary research on HIV, ranging from clinical to public health and policy research. Recent COVID-19 pandemic, she is actively participating and involved in managing COVID-19 patients as the chair of UMMC COVID-19 Task Force. The next speaker, we move on to Associate Prof. Dr. Sharifah Farida, who is Senior Consultant, Division of Infectious Disease, Department of Medicine, and also a head of Infectious Disease Unit. She holds a medical degree from University of Manchester, United Kingdom, and trained in internal medicine at the University of Malaya. As a head of Infectious Disease Unit, she is also one of the experts who has involved actively in handling COVID-19 patients and guiding the healthcare professional against COVID-19 in our center. Next speaker, who is well known to all of our cancer patients, Prof. Ho Guo Fong, who is an associate professor and clinical oncologist at the University Malaya Medical Centre, Kuala Lumpur. He was trained at BARTS and the London National Health Service, NHS Trust, and the Royal Marsden Trust in London. He attained his certificate for completion of specialist training, CCST, in 2007 and joined the Faculty of Medicine at University Malaya. He was the recipient of the Joint Commission International (GCI) Outstanding Young Malaysian Award in 2009 for medical innovation. He is the oncology lead for Center for Image Guided and Minimally Therapy, SIGMIN, stereotactic radiosurgery project at the university, as well as a sub-investigator for University Malaya's High Impact Research HIR grant project. His research interests involve breast, gastrointestinal, and gynecological cancer. He is involved in many national and international collaborative research work. Being a council member of Together Against Cancer, TAC, he champions cancer patients' right in Malaysia. The next speaker is Prof. Dr. Gan Gin Gin, is a professor and consultant of Division of Hematology, Department of Medicine, University Malaya. She graduated from University of New South Wales, Australia. She holds a MRCP as well as FRCP of Royal College of Physicians, United Kingdom. She also has a Master in Clinical Medicine in Leadership and Management from University of Newcastle, Australia. Her areas of expertise mainly in general hematology, hemato-oncology, hematopoietic stem cell transplantation. The next speaker is a Professor Dr. Sagunan Sokkalingam, is currently the head of rheumatology at the University Malaya Medical Center. He is graduate of the Manipal Academy of Higher Education's Kastuba Medical College and completed both masters in internal medicine and rheumatology subspecialty training in University Malaya. His research activities have focused on clinical trials using biologic therapy in lupus and rheumatoid arthritis. He is currently working on developing a registry of rheumatology cases in University Malaya. He is also a member of the Asia-Pacific Lupus Collaboration. His primary academic interest is the cellular molecular basis of autoimmunity and speaks on this subject both within Malaysia and SEA. The last but not least is Dr. Sylvia McCarthy, is the Medical Director of Hospice Malaysia. She oversees a team of doctors and nurses who deliver professional palliative care service to patients in their homes in the Klang Valley. Apart from the clinical work of attending to patients in the community, she is also involved in palliative care education and research. She is an honorary lecturer for University Malaya, University Putra Malaysia, UITM, providing palliative care teaching. She is also part of the teaching faculty for the Asia Pacific Palliative Care Network. She is on Palliative Care Technical Committee under the Ministry of Health Malaysia. Next, for the panel discussion, I humbly pass this platform to Prof. Aisha to initiate and continue our public forum for today. Please welcome Prof. Aisha.
Hello, Assalamualaikum warahmatullahi wabarakatuh. Good morning. I'm going to share my slides, so just hang on for a minute. Okay, can you see the slides? Wait. Okay, are you able to see the slides? So good morning, everybody, and welcome to the public forum. And I'm sure all of you are waiting to see what we can learn from this very murky area at the moment. So this forum really aims to educate cancer survivors, carers, and even healthcare providers on basic information on vaccines and issues surrounding cancer survivors. So we will be going into 3 different segments. The first segment we will be discussing, are all cancer survivors vulnerable? So we will have to discuss whether or not all cancer survivors are the same, different treatments, does it affect the vaccination program? Okay, for segment 2, we will then go on to talk about basic information on vaccines and types of vaccines. And segment 3, when we are preparing for the rollout, are we really ready? And we will try to address the question and answers that you have actually put into the chat box in both the Zoom platform as well as the YouTube live stream. So again, I would like to reiterate from what Dr. Suniza mentioned earlier, is that this forum does not provide individual medical advice, but it really is an overview of the issues surrounding the vaccines and cancer patients, and will be limited by the evolving updates in the scientific literature. So if you go on to the next slide, hold on. Yes, I think all of you have seen this infographic that circulated, I think, even at the beginning of or the middle of January, that actually caused a lot of anxiety, because when you look at Fasa 2, where the second risk category of people will be vaccinated, somehow cancer survivors was not included into this infographic from the Ministry of Health. Hence, I think the TAC went on to write a letter, and it's quite surprising that you can actually get a reply from the DG on the same day. Okay, so actually we put in the letter was published in the morning, and in the evening, the DG has mentioned clearly that cancer patients is going to be one of the vaccine priority groups. So I think we should be confident that this will be implemented in our cancer patients. All right. So there has been a publication that came out only like a few days ago on the 18th of February. So things are evolving very quickly for the nation. So you can find this publication quite easily on the website, Ministry of Health website. Okay, so please go and look at it. But it's a 26-page document, and we hope that we can discuss this today. So back to the phases of the vaccination. We won't go into too much detail for all the phases except for phase 2. And I think for everyone, everybody is worried about who are the people who will not be suitable for the vaccine or who are suitable for the vaccine. So you can see that there have been a lot of questions. I think I can see from the chat box, people are questioning, how about individuals with severe allergies? Can they take the vaccine? Okay. Women who are pregnant and lactating, although not the right forum, but yes, this is a group that is still a bit murky about, or not even murky, they're quite clear that it's not supposed to be given. And then individuals that have tested positive for COVID-19, okay, this we can discuss later with Prof. Adiba and Prof. Sharifah. And of course, I think for cancer patients, more importantly is that when individuals have immune system issues. So today we hope that we can clarify these issues. So let's start with the first segment, where I would like to invite Prof. Ho as well as Prof. Gan Jinjin to now discuss about this area of are all cancer survivors vulnerable? So I'd like to invite Prof. Gan. Are you ready? I will unshare my slides because you have slides to share. Okay, I will stop sharing. Okay, Prof. Gan, you can you tell us a little bit about what you think about this question?
Okay, good morning, everyone. Thank you for coming to the public forum. I'm not sure if you can see my slide. Can you see my slide?
Yes, we can.
Okay, all right. So thank you, Prof. Aisha, for inviting me to talk about vaccination, COVID-19 vaccination in cancer patients. As you know, I'm a hematologist, so I will only talk on hematological cancer patients, and I think Prof. Ho will continue on with other solid tumors. So before I say anything, I think a lot of informations are very limited, especially in regards to vaccination in cancer patients in general, especially in hematological cancer patients. So whatever I'm going to share is based on some of the international recommendations, and to be aware that this information may change depending on the upcoming scientific evidence. And as mentioned earlier on by Professor Dr. Noor Aisha, that decision for treatment or delaying treatment or going ahead with treatment or vaccination must be discussed individually with your treating physician. So I thought in the beginning, I just thought that as a general information for us to understand what are the published studies data on the trajectory of the patients with hematological cancer who had contracted COVID-19 infection. So one of the papers that was published last year in October, not too long ago, by the UK group, it is a UK cancer COVID-19 monitoring project where they look at 1,044 cancer patients in total. They found that the patients with cancer had a more severe COVID-19 trajectory. So we know that patients with chronic diseases or morbidities have a more severe COVID-19 infection, similarly with patients with cancer. Also noted that the patients who have hematological cancers also have a higher mortality rate. among the hematological cancer patient, acute leukemia patients seems to fare worse. And they also found that patients who had recent chemotherapy also fare worse than those who had chemotherapy for a while. But I think we should also be very careful with all this because there are a lot of limitation of the data. It may not truly be representative of all cancer patients or all hematological cancer patients. There are also other factors that were not taken into account, for example, other comorbidities. But to be fair, I think it would seem that patients who have underlying cancer, especially hematological cancer patients, may fare a little bit worse than other patients. Similarly, this is a big data that was a systematic review, that meaning that author and his group of colleagues look at many other studies that have been published. They look at 34 adult studies and 5 pediatric studies, which involve about 3,375 patients with hematological cancer. They found that the risk of mortality or death is quite high at about 34% in the adult, whereas the pediatric group seem to do much, much better. Older group again appear to have a higher risk of mortality. The ICU admission was also at about 21%, requiring mechanical ventilation about 17%. Again, acute leukemia seemed to fare worse than other hematological cancer. Again, like I say, these studies, although it is accumulative from many other studies, but it is also important to know that there's a caveat. These are mainly patients who were admitted. So obviously, when patients who are admitted, they have a more severe infection compared to those who can be managed at home. Interestingly, this meta-analysis did not show any evidence that patients who have recent anti-cancer treatment versus no recent treatment have any difference in the survival. So I think overall recommendation, should we vaccinate or not vaccinate? I think we need to assess risk and benefit, and I think that's where we are coming from, to have a discussion. But I think in general, recommendation is that patients who have cancer, including hematological cancer, should proceed on for vaccination. Again, then we have to talk about the types of vaccine. As we know, there are several types of vaccine in the market. Obviously, first one is our novel vaccine, the mRNA. And also, we also need to be aware what are the level of immunosuppression, not only due to the underlying disease, especially in hematological cancer patients, most of them are immunocompromised. And of course, the treatment that the patients have are also immunosuppressed as well. So the vaccination will then depend on what our level of immunosuppression and also the level of community risk. As what we have learned from previous vaccines, availability of vaccines, we know that patients who are immunocompromised, especially in hematological cancer patients, live vaccines generally we do not recommend. But I don't think we have any live vaccine for our COVID-19 anyway. Other types of vaccine, which include inactivated and protein-based from previous other types of vaccine, has been shown to be relatively safe for patients with hematological cancer patients. The novel vaccine like the mRNA and the viral vector, there is not much data in hematological cancer patients, but we would probably extrapolate that it would probably be the same as a general population, and it appears to be relatively safe as well. So I think I'll just have a quick general guideline. I think the timing of vaccination is very important because patients may be undergoing immunotherapy, they may be planning for transplantation, they may have had transplantation, they may be planning for chemotherapy. So the general guideline is that patients who have had transplantation, we would recommend 3 to 6 months after the transplantation. those patients who have had immunotherapy in general, also we will recommend 3 to 6 months. Not that because it is contraindicated. The reason the recommendation of 3 to 6 months after these procedures or immunotherapy is because we think that if you were to vaccinate earlier, the immune response may be attenuated. So you may not mount the same immune response as what we want. Whereas those patients who can wait to defer their treatment for at least 4 to 6 weeks, we would recommend vaccination, but the vaccination should then happen at least 2 weeks before the treatment or transplant, for example.
Prof. Gan, excuse me, is your slides almost ending?
Yes, it is almost ending.
Because I think we can really discuss this when we talk about vaccines, because I think there will be more basic information given to the participants on the types of vaccines later. So they may find that maybe you can discuss this later. The third.
I can stop here because this is the last slide anyway. So we will in the next section then. I will.
Yeah, I think we shall discuss this in the next session. So I think Prof. Ho, are you ready? Actually, Prof. Gan, there's a lot of comments. They want to see you. Your video is not on, so you should switch on your video. And then Prof. Ho
is on.
Yeah, your video is not on. Okay, Prof. Ho, are you ready? Are you able to? Yeah. Yes. Okay.
I need to share my slides.
Yeah, maybe you have to unshare, Prof. Gan.
Okay.
Okay, so I think Prof. Gan gave quite a good overview for hematological cancer patients, because I think most hematological cancer patients, even at diagnosis, may have issues with their immune system. So, okay, I think Ho, you're ready, right? Okay, we'll pass over to you.
Yeah. So first of all, the disclaimer. Actually, this presenting this is actually quite difficult for me, because I can see many of my colleagues are in the meeting, so many of them know more than me. So I just declared I'm not an expert in vaccine at all. But I will just, for the sake of public goods, I will just share what I know about cancer patients and COVID-19. So we borrow from the other authorities. American Cancer Society says, is it safe for cancer patients to get any type of vaccine? According to this authority, people with cancers or with a history of cancer can get some vaccines, but this depends on many factors, such as the type of vaccine, type of cancer a person has had, if they are still being treated for cancer, and if their immune system is working properly. So need to talk to your individual doctor before getting any type of vaccine. So the CDC recommendation for people who get priorities to get vaccine, so the healthcare professional usually get it first. But in the third paragraph, cancer patients and people with a history of cancer were not included in the first group of people the CDC recommended to get the vaccines, but people with cancer are included in one of the next priority groups, which includes people with certain high-risk medical conditions. So at least we know in the US, cancer patients are a priority group to get vaccine. The side effect of vaccines, this Professor Sharifah and Professor Adiba will talk about it later. Pain and or swelling injection site, tired, headache, fever, chills, muscle and joint pain. Cancer Research Malaysia, the latest update from 3 days ago, talking about shielding advice, people who need to avoid contacting the public. Many patients that they think are at extremely high risk. These are the lung and or oral cancer patients, blood or bone marrow cancers, like Professor Gan said, they are at high risk. Someone who is having chemotherapy or has received chemotherapy in the past 12 months, someone who had been prescribed prednisolone or immunosuppressants 4 times or more in the last 6 months. So we can see that, at least in the UK, they think these groups of patients are at particular risk of being seriously ill if they caught COVID-19. In terms of their people with cancer, whether they are prioritized to get vaccine or not. So the Joint Committee on Vaccination and Immunization prioritize the following groups for vaccination. So there are patients in care homes, very elderly. But in group 4, patients age over 70-year-old or clinically extremely vulnerable individuals. And group 6, individuals aged 16 to 64 with underlying health conditions which put them at higher risk of serious disease and mortality. They then clarify this and says that who falls into group 4 and who falls into group 6. So group 4 will include people who are clinically extremely vulnerable, i.e. people having active cancer treatment, as well as many in follow-ups. Other cancer patients, such as those treated a long time previously, who were treated surgically, will be covered by priority group 6. So that shows their opinion on who are extremely vulnerable, who are vulnerable, and they should get prioritized to receive the vaccine. Okay, so this is we borrow from the other authorities, so that it's not just my opinion. So so Cancer Research UK's opinion: if patient is participating in clinical trial, can they get vaccine? Yes, if the trial criteria say so. In the trial that we run, they only allow the they don't allow live vaccine, so which we don't have live vaccine, so that's okay. When is the best time to have vaccine? When I'm having treatment. This one, preferably have vaccine before starting treatment. But if patients are already on treatment, then the timing is a bit more sensitive. Have to discuss with individual doctors. Can I have the vaccine if I have low level of white blood cells, neutropenia? Ideally, you should not have an injection if you're unwell with neutropenia and until your level of white blood cells is normal. People who have chronic neutropenia should have the vaccine. So that answers that question. If the white blood cell level is low, if it is temporary, then you should wait for that to recover before you have the vaccine. For example, if patient chemo. Can I have the vaccine if I have low platelets or a bleeding disorder? This one, the healthcare team also has to decide whether it's safe for you to have the injection, because platelet level 10 and platelet level of 90 is different. It will depend on your level of platelets and the risk of bleeding. Can I have the vaccine if I have recently had an autologous stem cell transplant? This one, Prof. Khan just covered. I need to have it after 3 to 6 months of the transplant. I'm having radiotherapy. Can I have the vaccine? The vaccine is recommended for people having radiotherapy, and you can have it during treatment. This is because it doesn't affect your immune system like chemotherapy and other cancer drug does. I'm going to have surgery. Can I have the vaccine? Again, having surgery in itself is not a reason not to have the vaccine. Wherever possible, people who have surgery should have the vaccine 2 weeks before surgery. Can I have the vaccine when I'm having immunotherapy? This one is a bit more challenging. Immunotherapy can trigger an increased immune response causing side effects, but there is not enough evidence that it might happen with these vaccines, the autoimmune conditions, immune-related toxicity. Specialists say that the benefit of having the vaccine should be weighed against the risk of not having it and becoming ill with COVID-19. People having immunotherapy can have the vaccine at any time in their treatment cycle. So the general consensus is people having immunotherapy can have the vaccine. I want to read through this paper with you. It's just published 2 weeks ago, because it's the effect of the virus infection on our immune system. Actually, how does it affect the cancer patient's immune system? This is the big question, isn't it? And this also means that if patient has the vaccine, do they mount an immune response or not? So this paper from King's College London and University of Oxford look at the cancer patients who had the COVID-19 infection, or those who don't have the infection. So they recruited patients with solid cancer and hematological cancer, and those who had COVID and those who don't have COVID. So they look at their demographics, cancer status, treatment status, all the parameters, and then do serial PCR for the virus, and then look at their immunological analysis. So this is just the demographics. It's not a very big study, as you can see. These are very sick patients, but it is as good information as we get. So the patients who cancer patients who had COVID, 41 patients, and those who have cancer but do not have COVID, 35 patients. You can see the two groups: the age, the sex distribution, the BMI, and then other comorbidities, and they are reasonably balanced. So for what kind of cancer patients we are talking about? Solid malignancies, solid tumors in 56% and 74%. So these are women cancers, urological cancers, GI cancers, lung and head and neck cancers, and hematologic malignancy in 43%. But you can see that the non-COVID patients actually are more solid tumors than hematological cancer. So these are a diverse group of patients from stage 1, stage 2, stage 3, and stage 4. So you can see many patients are actually quite sick patients. Half of them have stage 4 cancers, and then also at different stages of diagnosis. Some are recently diagnosed, some are during treatment, some are after they have completed their treatment. 41% have completed their cancer treatment or ongoing treatment as a maintenance treatment. What kind of treatment these patients are on? Primary radical treatment, surgery, neoadjuvant or adjuvant chemotherapy or targeted therapy, palliative treatment, watch and wait surveillance. Some are missing data. And a lot of these patients are on high-dose steroids. So you can tell these are a group of very vulnerable patients, either those who had the COVID infection or those who don't have the COVID. So what is the outcome? So these are different cancer types: urological cancer, GI cancer, women's cancer, lung cancer, and hematological cancer. So these are the groups that have mild symptoms after they get COVID, a quarter of them. And these are a group that have severe symptoms if they get COVID. You can see hematological cancer patients tend to have moderate or severe symptoms. They tend to be more sick if they have COVID infection. The GI cancer patients tend to be having milder symptoms. They tend to be in this group. The rest, urological, lung cancer either mild or severe. Urological and women's cancer tend to be has a even distribution. This graph is a bit complicated.
Okay, Dr. Prof. Ho, we don't have much time.
Okay.
So can you summarize at least to make it simple for our public, the listeners? Thanks.
So these blue dots are patients who have immune response. This yellow, for solid tumors, these are hematological cancers. So they find that many patients, in fact, most patients, develop immunological response to the SARS-RBD protein, spike protein, or nucleocapsid antigen. So contrary to common belief, the patients do mount immunological response. For the spike protein, 3/4 of patients would mount antibody response to COVID, to spike protein. And then the solid cancer patients have earlier seroconversion than the hematological patients. And all those who have negative swab tests manage to seroconvert, i.e. they manage to develop antibodies. And the hematological patients fail to mount antibody response, or they fail to clear the virus, or some of them mount antibody response and clear the virus. And the antibody titers for patients with either solid or hematological malignancies were comparable to those of COVID-19 non-cancer patients. So this is quite reassuring. The cancer patients who got COVID, they mount equal amount of immune response. This should show that hematological cancer patients tend to get admitted a bit more, the yellow line, but there's a lot of death in the solid cancer patients, the red dots. So this is actually quite concerning. And this graph is important it says that for the patients who get COVID, within 1 month, a fifth of them have died, and compared to those who do not get COVID. But actually, most of the cause for death is actually cancer disease progression rather than COVID per se. So especially those who get moderate or severe disease, they tend COVID infection, they tend to have cancer progression quickly within 1 month of the diagnosis of COVID. So this is something we need to bear in mind. Getting COVID in cancer patients is very bad news. In summary, the COVID signature for solid cancer patients was a consensus phenotype, which is the standard immunological response compared to patients without cancer. And some properties are a bit different, but basically majority of patients can establish immune response just like non-cancer patients. Evidence of sustained seroconversion in solid cancer patients, providing some measure of confidence that cancer patients are not necessarily at a higher risk of an inferior immune response, i.e. the immune response is pretty good to SARS-CoV than the general population, and suggests that the principal cause of elevated mortality risk from COVID-19 in solid cancer patients is cancer progression, which is correlated with the severity of COVID-19.
Okay, I have to stop you there, Prof. Ho. I think you've given a fantastic overview, and you can see, I think from the first segment, there are few take-home messages. One, the type of the cancer survivor, not all of them are vulnerable to different degrees. They're all different degree vulnerability. So you can say that whether they're on active treatments or not, right? And the type of cancer that they have may give them different risks as well. And of course, the type of treatment they are on. And the last one, I think, more importantly, I think what you have shown is that they can mount an immune response. Even in the most sickest patient, they can mount an immune response. So I think we'll stop here. There are a lot of questions from the public about the type of treatments. Maybe we can cover that later during the Q&A session. So we will now move on to segment 2. Okay, segment 2, I think we want to go back to basics, because I think for most of us, as even the practitioners, immunology is something like we've forgotten from medical school. So we would like to bring on our two eminent speakers, Professor Sagunan as well as Prof. Adiba, because this area is more, they are the experts in this area. And I think Prof. Sagunan will be starting first to explain to us what is basic immunology. How do people mount responses, and how is that important to us when we want to understand the vaccines? Okay, Prof. Sagunan, are you there?
Yes, can you hear me?
Yep, you can start sharing.
Okay, great. Okay, so hi everybody. Thank you very much for having me in this forum, Aisha. And I've really learned a lot from the previous speakers. So thank you very much for the opportunity. Right, so bear with me. I'm going to try this. I'm going to try and share my slides. Okay, so I think you can see something. Right, hold on a second. Can I have a confirmation if you could see the slides?
Yes, we can see your slides.
Okay, I'll go to full mode and confirmation again. So I can start, yes?
Yeah.
Okay, thank you very much. So welcome everyone. And I really hope that I don't frighten you with what I'm about to show you, because there's a lot of the science in this. It's very technical, but I'm going to make it very, very simple for everyone to understand, to give you the confidence that no matter what situation you're in, what medications you're taking, what type of illness you have, whether you are sitting on your office or sitting at your home or flying in a plane, you have an immune system that's working 24/7. Whatever the situation, your immune system is working 24/7. And I'm going to show you that right now. You see, immunity is basically protection from disease, and more specifically, infectious disease. But please remember, and I know many of you, many of the people in the public are people who have had experience with cancer. The immune system actually monitors for cancer cells as well. The moment a cell is showing mitosis of atypical origin, that means a cell is trying to become cancer, your immune system is trying to protect you. So that is also the function of the immune system. As with cancer, also with infectious diseases, some infection can somehow bypass all of this and create very sick situations. Now, the immune system is basically the cells and the components of your immunity. So you say that my immune system, so you have an immune system that gives you the process of immunity, and how it responds is called the immune response. So you'll hear these words every now and then. Now, I told you just now that we all have an immune system. And what this immune system is about, don't worry about how complex the slide is, just follow my arrow. There are two forms. One is called innate immunity. That means it is there naturally whether you like it or not. You have skin, and that is your first protection from disease. And you have all these cells called phagocytes, dendritic cells, complement cells, NK cells. These are part of what we call the innate system, innate immune system that is already there, ready and waiting to take on any pathogens. And then what you have is adaptive immunity. What is adaptive immunity? Adaptive immunity is when, as a person gets an infection, within a few days, there are cells that learn what this infection is and design a kind of an antidote or an antibody or cells that kill this particular infection. So that's how slick your immune system is. And in particular, in viral infection, what happens? So in viral infection, if you look at what is released after, you see this IFN. So IFN is what we call as interferon, specifically for virus. And you have interferon type 1, which is made of interferon alpha and beta. And look what happens. As soon as the infection comes in, within days, you have the interferon levels going up. And interferon is what makes people very sick during an infection. The joint pains, the body pain, the high fever, the feeling that, you know what, things are just horrible. That is because of the interferon. So in that sense, you know, having that fever just means that you're fighting the infection, and that's actually a very good sign. Now, there is a particular type of cells, and you heard so much about what our colleagues spoke earlier, about how there's this thing called immunotherapy, and many of you, perhaps some of the patients here are on immunotherapy. Now, that is something very interesting, and our body already has the NK cells, which the moment a virus comes in, it goes there to try and defeat the virus. Then after that, what happens? There are two types of the cells that are involved. One is called the cytotoxic T lymphocyte that is now going to rise. And what these lymphocytes do is to actually try and kill the virus. And the B lymphocytes that create the antibody. So this is the adaptive immunity. So what happens is that your immune system can, number one, protect you against infection or eradicate the infection. Now, how does that happen? In innate immunity, the virus, when it infects, when it tries to attack the cell, the interferon tries to protect this, okay, and creates what is called an antiviral state. That means the cells already have a sort of a defense around it. And then what happens with the antibodies? Antibodies do the same thing as well. When the antibodies against the specific virus have been created, what they do, they actually neutralize the virus. So that protection against infection. But what about eradication? Yes, the NK cell, as I told you, will try and kill the infected cell. And also what we call cytotoxic T lymphocytes, we also try to kill the infected cell. So the body already has these protective mechanisms. But what happens in a viral infection? So basically, the moment the virus gets in, what the virus does, it engulfs the cell and it creates it makes the nucleus secrete RNA and DNA that creates copies of the virus. And these copies of the virus then escape to infect other cells. Now, look at what's happening here. The question is, so does the virus kill the cell? Actually, it doesn't work for the virus to kill the cell. The virus will try to keep the cell alive so that it can get more copies of itself. So in that sense, what happens is the cell just stops working like a normal cell. So that's not good. The other thing that happens is, of course, what we are hearing in COVID-19 problems is that the moment that the virus infects the cell, there's another response that comes out where all the cells of the immune system now set off by creating what is called a cytokine. And these cytokines create tissue damage. And this tissue damage then releases more cytokines. And what happens is called a cytokine storm. And that is why some people get very sick. they end up in the ICU, they end up requiring ventilation, their BP can drop, they have difficulty in breathing. And if you don't stop this process, unfortunately, it's not really a very good thing. And let me tell you, all of us have the capacity for this kind of a situation. And therefore, again, I repeat, whatever your situation, whether you are on the plane or whether you're sitting in the house, whether you're taking medicine, whether you're on chemotherapy and so on, that should not stop people from taking the vaccine because your immune system is still functioning. Yes, it may be suppressed to some extent, but the issue with suppression is not that, oh, the moment I get the vaccine, I will die of COVID or the COVID gets worse. No. The problem is because of all the therapy, the body doesn't produce antibodies for a vaccine the way it's supposed to. Now, you have various drugs to defeat the virus, whether it's oral or antiviral. And I just show this because many people believe that rasam, you know, the Indians, we like rasam, and apparently rasam can treat COVID, but well, I mean, I wish that was true. Initially, maybe it worked, but then over time, I think people who took rasam still got sick. So what happened was, now let's talk a little bit very quickly about vaccines. This is a picture of Edward Jenner, who in 1789 injected his own son, 1.5-year-old son, with the cowpox secretion. And here you can see the cow looking at it and looking at this whole situation. And his 1.5-year-old son then later was exposed to the smallpox virus. The son never got smallpox. And smallpox was a very deadly disease. And because of the work of this Englishman, Dr. Edward Jenner, in 1796, we have the first vaccine. So 1796 people, we have been getting vaccines from them, and it has completely eradicated the disease of smallpox. There's one disease you will never see on planet Earth, and that is smallpox, and that is because of vaccination. Perhaps someday we will see the same of COVID-19. And here is a slide, again very busy, to show that how in a community in the United States, all the diseases because of vaccination, whether it is bacterial or viral, have been reduced to fantastic levels, minus 99.99% change, minus 100% change. Yeah, so you can see the success of vaccination. Now, what are the common types of vaccines? Well, the vaccine that everybody quite aware of is a killed vaccine. Now, killed is basically inactivated. What is it? The bacteria or the virus is dead. It's not at all active. It cannot proliferate. And what happens is that when you inject it, it triggers an immune response. So we have all these examples: inactivated polio vaccine, flu vaccine, hepatitis vaccine, and so on. But do remember, the killed vaccine is not the most powerful vaccine in that, yes, it can trigger an autoimmune, an antibody protective response, but it is not sustained. You may need booster doses later or repeat doses. The most powerful vaccine that we have today is the live vaccine, which is attenuated. That means, yes, the virus or the bacteria is somewhat alive, but it has been almost like the dangerous part of it has been removed. The technology is available today. So it is absolutely really safe. And many of these vaccines are being used today with great degree of success. And it activates both the antibody activity and also the cytotoxic activity, and it can last for quite a long time. Yes, so these are the most powerful vaccines that we have. Now, what we are hearing now are the subunit vaccines. That means they are part of the microbe. A part, that means they're just only maybe the cell wall or the part of the DNA or the RNA. And the recombinant DNA vaccines are the example. And hepatitis B vaccine, the HPV vaccines, meningococcal vaccines that many people take before they go to do their Hajj, have saved millions of lives. Yeah. So there are also other vaccines that use toxins, inactivated toxins. So these are for diphtheria, pertussis, and tetanus, the so-called DPT vaccine. Now, we are talking about another vaccine called the nucleic acid vaccines. Now, I won't get much into this because I believe the subsequent speakers, Prof. Adima, might talk about the mRNA vaccines. So basically what they do are, these are new technology where they actually take the RNA, inject it into the host, and what happens is the RNA just gets the body to produce, as I showed you, the antibody that will defend the host eventually. So there's RNA vaccines. We do not have actual pure DNA vaccines now, but we do have viral vector vaccines. Some of those vaccines, the one that you hear from Russia, are viral vector vaccines. The the vaccine from Oxford is a viral vector vaccine. And of course, we know today, I believe the first shipment of mRNA vaccines just arrived in KLIA as I speak. So yeah, ladies and gentlemen, that's all I have to talk for now. I will stop here and leave for the next speaker. Thank you very much.
Thanks, Prof. Guna. So I think we've gone a bit through that, and now we're going to invite Prof. Adiba, Datuk Prof. Adiba, to present her slides and give more details about the COVID-19 vaccines that's available in Malaysia. Prof. Adiba.
Just give me 2 seconds
Okay.
whilst I get this up and running.
Okay.
Okay, can you all see?
Yep. Yes, we can see.
Okay, good morning, everyone. And it's really, really encouraging to see so many people online. Obviously, there's a lot of excitement now that the vaccine has arrived on the Malaysia Airlines cargo flight this morning. And but as Aisha kept repeatedly saying this morning, there's a lot of murkiness. The reason for that is, I think, because of the speed at which the vaccine's been developed. Well, first of all, the whole COVID-19 pandemic has kind of, when you think of it, it seems like we've been in it forever, but it's only really been 14 months. And the science that and the knowledge around the virus itself and the clinical disease and now the vaccines has been like unprecedented, as you keep hearing about it. And of course, the fact that the vaccine, the different types of vaccines have been given to millions of people. So last estimated at 148 million doses in, of course, the high-income countries is nothing short of a medical miracle. But along with that, we've had quite a bit of confusion. And then, of course, it doesn't help that there are established anti-vaxxers ever willing to, promote all kinds of conspiracy theories and, all kinds of, amplify negativity so that so many people, including healthcare workers themselves, who are afraid to take the vaccine. So you've heard, my colleagues tell you why it's a good reason, even if you've had cancer, to take the vaccines. And you've heard Prof. Sagunan explain how the immune system works. In short, I think it's extremely important for all of you to consider taking the vaccine for 2 reasons. One is, of course, to protect yourselves. And what we know of the vaccine now is it reduces the severe disease that about 15 or so patients who contract the infection are prone to get. And the second is, of course, and hopefully all of you will agree with me, for a more altruistic reason, and that is for public health reasons. The more people who get vaccinated, the more quickly we reach that term that suddenly has become familiar to everyone, herd immunity, and which will then protect people who, for whatever reason, and this might include some of you, who cannot be vaccinated. So these are the 2 main reasons why you need to be vaccinated. Now, just quickly on severe disease, my colleagues, Sagunan himself, myself, Prof. Farida, who you will hear a little later, have been looking after patients at UMMC with COVID-19. It's very clear that those who are going to run into trouble are those who are aged over 60. I mean, we know about this from large cohorts from around the world, starting from China, and then, you know, when the Italians started getting large number of people, and then the UK and the US, the pattern is the same. Those who are going to run into trouble are those who are over 60, those who have diabetes, those who have heart disease, hypertension, and to a slightly lesser extent, those with cancer. And so, you know, it's very real, and with the level of community spread that we are having in Malaysia at the moment, particularly in Selangor and KL, you have a much higher chance of getting infected with COVID-19 than when you get that vaccine in your arm of getting a severe side effect. I think that that's very important to make that very clear up front. Yes, 70. You will hear the anti-vaxxers saying, but most people who get COVID-19, you know, are asymptomatic or have very mild symptoms. It's like the flu anyway. Yes, in 70%, 80%, or maybe even higher, 80% of people, it's mild disease. They may not even know that they've been infected, but these generally tend to be younger people with no other diseases. I mean, 20% of people doesn't sound very many, but 20%, if we allow the pandemic to continue and get bigger and bigger, then the 20% could be more and more, and could include, you know, hopefully not, one of you. And as I said, if you're over 60, have all those things that I mentioned, you stand a very high chance of getting severe disease. And when we mean severe disease, it is, you know, difficulty breathing. You may need, you know, to have support with a ventilator, etc., etc. It is not a nice disease. Believe me, it is not a nice disease. So having stated my case for getting all of you vaccinated, now just a quick, you know, sort of run through what these vaccines are. So like I said, it has been unheard of, you know, at 14 months since the pandemic was recognized and declared, that we have, you know, over 70 vaccines in clinical trials, and 89, there's still ongoing preclinical vaccines under investigation. So 37 vaccines in phase 1, which is testing for safety and dosage, and 28 vaccines in phase 2, which is looking for safety, small scale safety trials, and then phase 3, which is this large, you know, thousands and thousands of people, what we call the efficacy trials. 6 vaccines in, this is for the US, and 6 vaccines in early or limited use, 4 have been approved for full use, and 4 vaccines have been abandoned after clinical trials. Now, it is important to understand a little bit about these phase 1, phase 2, phase 3 trials, which are what we would do when we are testing new drugs, when we are testing new vaccines, because there's been a lot of concern about, you know, have these vaccines been rushed? Now, all of the approved vaccines, including of course, the Pfizer vaccine that's arrived this morning, that's going to be first off the rank in Malaysia, have had to go through this phase 1, phase 2, phase 3 clinical trials to ensure that to look into the safety. So there's been no shortcuts in terms of these big pharma vaccines, the ones that have been approved. The reason why it's, you know, people would say, but, you know, we still don't have the HIV vaccine. After 40 years, we still don't have a good TB vaccine after I don't know how many decades. We still don't have a, you know, a very good dengue vaccine, for instance. We have a dengue vaccine, but so, you know, and normally it takes about 5 years to get to a good vaccine. Now, how come, the skeptics are asking, how come we within 12 months or even less, within 10 months, have been able to get a vaccine and within 12 months get it into millions of people's arms? And the answer is because Sagunan just very eloquently went through the different types of vaccine around the world. So the technology is already there. It's not something new, especially for the inactivated vaccines and even the the viral vector vaccines and the mRNA vaccines. So the technologies are all there, waiting to be utilized for the SARS-CoV-2 virus that is causing COVID-19. On top of that, the SARS-CoV-2 virus is not a new, well, it is a new virus, but it belongs to a very well-known family of viruses, the coronavirus family. When the original SARS caused, a pandemic as well, but was fortunately limited, there's been a lot of interest. There's always been a lot of interest. So there are many, many groups of scientists around the world studying the coronavirus. So when SARS-CoV-2, COVID-19 pandemic hit, groups of scientists from around the world started working immediately. And if there's been a silver lining in this pandemic, is that it's taught scientists from all around the world to work together. And that's that's the second reason why we've managed to get these vaccines so quickly. So one is the technology is, it's not new, although people keep talking about this mRNA technology is new. It's actually not new. It's been around, people have been testing it. Secondly, the virus belongs to a family of, well-studied virus. Thirdly, a lot of money was, thirdly, scientists got together and worked together. Fourthly, a lot of money has been poured into development of vaccine by the US government, by EU, by pharmaceuticals. The Pfizer vaccine, the Pfizer refused money from the US government and just went on and did it themselves. And number 5 or number 6, I've lost count, is that many people, so you see this large scale clinical trial, this phase 1, phase 2, phase 3 trials, you have to get people to come forward to volunteer. So phase 1, phase 2, generally you don't need very many people, but phase 3, you need thousands of people to volunteer. And people came forward and volunteered very, very quickly to participate in these trials. So the trials were able to be done quickly. And on top of that, because the pandemic is roaring, they were able to reach what's called the endpoints to see, the endpoints in this case is the severity of disease, because a lot of people who were not getting the real vaccine, who were getting the placebo, were in fact getting infected because there's so much active infection going on. And that's usually one of the reasons that trials are slow to reach endpoints for other vaccines, because there's not a lot of active infection going on. So if I can debunk the skeptics that say, oh, these vaccines have not been done properly, the answer is no, at least for the ones that have been approved by FDA and the EU and Malaysia, hopefully, they have to have gone this phase 1, 2, 3 normal standards of getting either a new vaccine or new drug into the market. Okay, so that's that. On top of that, with this more than 140 million doses that have been given, many countries that have participated in this have, and Malaysia will be doing the same, have what's called a pharmacovigilance program in place, which means every single person who is injected with the vaccine will be followed up to see if there are any side effects. Okay, so there are many, many vaccines, and I think that has also led to the confusion as to what's what. The two that's, I guess, most famous are the Pfizer-BioNTech, the mRNA vaccine, And the Moderna, I think the Moderna vaccine, we will probably not be getting it anytime soon. The Russian Gamaleya or the Sputnik vaccine is using a different technology to the Pfizer and Moderna vaccine. It's an adenovirus vector vaccine. Same with the Oxford AstraZeneca. And then you hear about the Chinese vaccines, right? Chinese vaccines are the Sinopharm, Sinovac, CanSino, quite a number of, there are at least 4 or 5 Chinese vaccines. And in Malaysia, I believe we're participating in the clinical trials using the China vaccine. So we're doing those phase 3 trials that I'm talking about. The reason why many countries have not, some countries have expanded use, for instance, China, UAE, Bahrain, Egypt with the Sinopharm, and Indonesia as well, and many other countries. The reason why I think Malaysia has not rushed into these Chinese vaccines, because at the moment, the data around them has not been published, or, you know, that there's been less kind of transparency compared to those pharmaceutical vaccines that have been approved. So this is why, you know, I think a lot of people are asking why aren't we using the Chinese vaccines, and that's the reason why, because you know, the conventional way of approving vaccines is through reports in journals, and then putting the dossier in, and so that has not been totally accomplished by the Chinese vaccines yet. I hope that it will be done soon, and we'll be able to know how they perform. As you know, then we can have more different types of vaccines to be used. The other vaccine is the Johnson & Johnson, and I believe there's negotiations underway with this. This one is pretty exciting because it only requires 1 dose. Mind you, recent reports from the US looking at the immune response with the Pfizer-BioNTech vaccine is also suggesting that 1 dose may be good enough, but you know, more studies will need to be done before that can be approved as the way to go. Because obviously, if you need 1 dose, you can vaccinate more people.
Okay, Prof. Adiba.
Yep.
I think our time is like almost.
I know. So I won't go into the different types. I mean, these are, you know, very fancy graphs on fancy cartoons on how the different vaccines work. Just very quickly on the mRNA. New technology, but has been around, and in fact was going to be used for the SARS vaccine itself. But you know, SARS, the original SARS, went away. What's causing the side effect is this nanoparticle that is part of the vaccine structure, and it's not the vaccine itself. But since Aisha said I'm running out of time, I won't go into too much detail. So with the different types of vaccines, so this is, you know, these are the types. So the viral vector vaccines and the protein vaccines, so far, no major side effects. The costs, and I have to thank Dr. Musa, whom I think many of you would have heard speak very, very passionately about the vaccines. So there are pros and cons to the vaccines. Of course, the major concern with the Pfizer-Moderna vaccine is still the anaphylaxis, which is that severe difficulty breathing and drop in blood pressure, but it's still extremely rare. It's 4.7 per million, and for Pfizer, and 2.5 per million for the Moderna vaccine. And it's still, compared to the other vaccines, it's still one of them. It's still the most efficacious in terms of the types of vaccines. Now, recent studies have also, from Pfizer, have also shown that it may not, in fact, need this -70 storage, which obviously is a problem when you want to bring this vaccine to districts and to rural Malaysia. Recent studies by them showed that it can be kept in -20 fridge versus -70, research type freezers for 2 weeks. So Israel is leading the world in terms of number of people vaccinated, followed by UAE, UK, US, and so forth. And hopefully by next week or the week after, Malaysia will come on board as well. And what it has been shown in Israel is with a large proportion of their population being vaccinated, they're starting to see reduced hospitalization and reduction in severe disease. So that's the other important thing to remember, that thus far what the vaccines are doing is to reduce one who has been vaccinated from getting severe disease, which is what we want, reducing severe disease, reducing death. Whether it reduces transmission, there are now studies to show that yes, it does that as well. But those studies are still ongoing. However, early studies shows that yes, it does reduce the ability to transmit the virus to other people as well. So maybe, Aisha, I can stop there for now. And then we can take questions at the end. Yeah.
Okay, thank you so much, Prof. Adiba and Prof. Sagunan. I think that gives a stage of, understanding a bit about the vaccines and the different types. So now we're going to move to segment 3, and we're going to answer a lot of your questions. I think we've got like 500 people on Zoom, and I think I don't know how many people on YouTube, but there are a lot of questions. So don't worry, we will be addressing these questions pretty soon. So we will now move on to the segment 3. Let me just share my slides. Can you all see my slides? Yep. Okay, so we will be now moving on to segment 3. We will be having everyone in the group to be part of the discussion. Let me see, segment 3, we have all our speakers with us. Me and Prof. Gan will be co-moderating because we're going to try and answer all your questions later. But we have now on board is Prof. Sharifah Farida from UMMC and Dr. Sylvia McCarthy from Hospice Malaysia. So are we really ready for the rollout? So maybe we'll give some time for Prof. Sharifah as well as Dr. Sylvia to give some comments about this. And then we will quickly do some rapid fire answering your questions section after that. Okay, Prof. Sharifah?
Thank you, Prof. Aisha. Also, thank you for inviting me for this forum this morning. Amazing, more than 500 people are on board. I actually feel a bit guilty because everyone has slides. I was wondering if I could show. Yeah. Okay. If I can get it on.
Do you need to share slide?
Yeah.
Okay. All right. So maybe while waiting for Prof. Sharifah, I think so far what we've learned from the 2 segments is that cancer patients can mount an immune response to the vaccines even though they have issues about immunosuppression from the treatments, okay? And then we know from what Prof. Adiba mentioned, this is a public health issue. We are facing a pandemic and the issues about herd immunity is important. And she's mentioned many things which we will talk about later. I think Prof. Sharifah is now ready.
Yeah.
Yep. So, okay, go ahead.
Thank you. So apologies if these slides are not perfect, but these are just some slides that we got from the Ministry of Health as we are preparing ourselves to roll out the vaccination program in Malaysia. So just to say that, the whole point of vaccination program in Malaysia for COVID-19 is one to reduce the burden of disease, which includes morbidity and mortality. and also to protect our frontliners. And at the same time, at the end of it, after we vaccinate as many people as we can, hopefully we'll get some herd immunity so that we can protect those that cannot be vaccinated. And then obviously at the end of it, we want to try and control this pandemic that's been hounding us for the past 1 year or so. So it is purely, purely voluntary. There needs to be a written consent for it. So there's nobody will be forcing anyone to take the vaccination, including for the frontliners. But it is highly, highly encouraged, and we hope as many people will come forward for the vaccination if they are eligible. So the first vaccine that's going to come in, as you all saw, that it just literally landed in KLIA, is a Pfizer vaccine, which are 2 doses to be given at least 21 days apart. And the overall plan, so we've been going for this briefing, but I think this is one of the biggest vaccination program that we've ever embarked on. It's mainly handled by Ministry of Health and also most.
Sorry to interrupt you. A lot of people are saying they can't hear you.
They can't hear me. Oh God. Aisha, can you? What's the problem? Yeah.
I think you speak a bit louder. Speak a bit louder.
Okay. Can you?
Yeah.
I hope it's a little bit better. Yeah. Sorry. And I'll try to slow down a bit. So this is one of the biggest vaccination programs that Malaysia is embarking on, and to vaccinate as many people as possible in a very short span of time is a big hurdle. So KKM especially has been having endless meeting, I'm sure, trying to plan this out as much as best as possible. So the overall plan is to try and vaccinate 70 to 80% of the population in the next 1 year. And it's broken down into 3 phases. So the one that will start immediately is the one for the frontliners. So Fasa 1, and this is targeting about 500,000 of frontliners, which is only about 2% of the population. As we are finishing Fasa 1, then they will start with the kumpulan berisiko tinggi, which is what this forum is probably most interested in. And then once they've reached a good number of people who are at high risk, then they will move on to Fasa 3. And Fasa 3, this is where the herd immunity comes in, where we hope to vaccinate as many adults as we can to provide that herd immunity. So in terms of timeline, so the Fasa 1 will start almost immediately in the next 1 week or so. UMMC is hoping to start our vaccination program on the 1st of March. And hopefully this can be completed within 2 to 4 months, depending on the number of vaccines that we receive. And then, as you can see here there's an overlap with Fasa 2. So Fasa 2 will start as early as April, probably May, when Fasa 1 has not even finished yet. We have not received the details of Fasa 2 in terms of which facilities will be used, where will it be done, but there are some plans already on how to cope with it. And then finally, Fasa 3, which is where we hope to reach herd immunity, will start soon after Fasa 2 has been rolled out. So in terms of where the vaccines will be given, so Fasa 2, as it is for frontliners, obviously the places will be where hospitals are, klinik kesihatan are, kementerian, because obviously our army and all that are also involved, and also hospital university for our staff. Fasa 2 and Fasa 3 is the one where we involve public. So at the moment, the plan is just ditentukan kerajaan dan fasiliti kesihatan swasta. But I can tell you that they are planning big. So, we're talking about opening halls, areas, but they haven't given us the details into whether patients can come to their respective hospitals to be vaccinated. You're already a patient under follow-up in UMMC. Will you be able to come to UMMC to get your vaccines to UMMC? So that has not been detailed out yet. I think they're really focusing on getting this Fasa 1 out and running and vaccinate as many frontliners as they can before they can tell us the details of Fasa 2 and Fasa 3. So as you can see, the overlap between Fasa 1, 2 dan 3. As you can see, there's also a lot of cabaran, if you like. The vaccines, even today, we only got about 300,000 plus vaccine doses, when we actually need 1 million for us to vaccinate 500 frontliners. So it doesn't come in one go. It'll be coming in phases, and therefore the rollout of the vaccination will need to be done according to the amount of vaccine that the ministry receives too. So this rollout, the first rollout, we are going to receive the Pfizer vaccine. The majority of vaccines acquired by Malaysia is Pfizer, but as Prof. Adiba had mentioned, there are some problems with Pfizer's vaccines, especially in terms of storing it because it needs a ultra low temperature freezer. So in terms of contraindication, when we speak about the the Pfizer vaccine, so as Prof. Adiba has mentioned, the only real contraindication is any severe allergies or anaphylactic shock. It's very, they've written here system immunity tubuh yang rendah, pesakit cancer, but there's really not much detail. So this is a case by case basis, and it's not like an outright exclusion criteria. They've also changed this a little bit in terms of pregnancy and lactating women. So again, when all these vaccines were done in clinical trials, certain groups were excluded, including pregnant and lactating women. Therefore, we do not have the data in terms of safety data. Therefore the initial recommendation was, this vaccine should not be given to pregnant or lactating women. However, the vaccine has been given to millions of people in the US, the UK, and elsewhere. And based on the post-vaccination surveillance, they have not seen any red signals or flags to be worried about in terms of when pregnant women and lactating women receive the vaccine. So a lot of guidelines have now said, counsel pregnant women and lactating women who want the vaccine, weigh out the pros and cons, especially if the person also has other comorbidities that makes them vulnerable to COVID-19, and then get a consent to have the vaccine. So I think when it comes to cancer, it'll probably be along the same lines. Prof. Gan and Prof. Go both gave an excellent overview of cancer and also COVID-19, and I think we've already got some points there in terms of who should we advise, who should be getting the vaccines, and so on in terms of cancer patients. Another very, not very detailed slides about who they consider or ministry consider kumpulan berisiko tinggi, 60 years and above, and all these comorbidities, and cancer is one of them, but no real details as to, what stage of cancer and so on. In terms of enrollment, so Fasa 1, we actually have to submit names to Ministry of Health to get the vaccine. But when it comes to the public in Fasa 2 and Fasa 3, we're talking about not just submitting names. So I assume this is going to be from the list that we have from clinics and the MySejahtera. So MySejahtera is going to be your best friend after this. Make sure you have it on your phone because it's a way, I don't think it has been activated yet. So don't worry if you open your MySejahtera now and you don't see anything on it yet. They're really, really concentrating on getting this phase 1 going before they can go into detail with regards to phase 2 and phase 3. So I think that's all I have to share. Let me just stop sharing.
So I think that was very nice, and I think gives some reassurance that there's work underway, and it's just that things are evolving quickly, and we should just trust that there is a plan, right? Okay, now, yeah, isn't it? Okay, so before we go further, maybe we'll give some time for Dr. Sylvia from Hospice Malaysia to maybe give some perspective from people who are actually working in the community itself with cancer patients. Dr. Sylvia, some comments? Yeah.
Yes, sorry. I don't have any slides because I'm really not an expert on vaccination, but thank you very much for inviting me just to talk a little bit about what's happening in the community. I think that the pandemic has obviously brought with it a lot of anxiety for patients with very advanced disease. And so community services have increasing importance. I think the problems of going to hospital, of requiring isolation before being PCR tested and so on, make the decision about hospitalization very difficult. And if you can have more community services looking at how much care can be provided at home, or whether a good assessment can be done to see whether hospitalization for a particular condition really is necessary or not is very helpful. And I think part of the response needs to be looking at strengthening community services to an extent. In terms of vaccination, very difficult to know at the moment how patients who are both vulnerable and have difficulty going to hospitals are going to receive their vaccinations. And unfortunately, we don't at the moment have information about that. I think Prof. Ho mentioned, where should cancer patients be receiving their vaccinations? Should they be going to the larger centers or through their consultants? And I think that's a very important question that we don't have answers for. So that's just my little addition. I'm very happy to take any questions.
Okay, thanks very much, Sylvia. I think we can all now, I'm talking about the panelists, you can all unmute and put on your videos, because we're going to try and see how we can answer all these questions that's been popping up since the beginning. So I think maybe we can start first with identifying who are the vulnerable cancer patients, because these are people are asking. Some are off treatment, some have been having treatment 20 years ago. So can we get Prof. Ho and Prof. Gan, either one of you, can you tell us now, is it safe for cancer survivors to have vaccines?
Sorry.
Yeah.
Oh, you want to speak first?
You want to start?
You go first.
Okay, all right. I can only speak for hematological cancer patient. Generally, I think data is still very limited to see how patients who have had vaccination in hematological cancer patient. But from what I have presented, we can see that hematological cancer patients, they do fare worse compared to the general population. And because of that, and so far there is no adverse effect that seem to be terrible with vaccination. So I think the advice is to go ahead with vaccination. I think the issue is the timing of vaccination. And I can see from the questions, a lot of people are asking what are the timing of vaccination. I think that's one thing that we have to discuss. And second thing, I think it's also that the vaccination, there are certain group of patients who may not be advised for vaccination, especially in patients who are very severely immunocompromised, especially those patients who have very severe neutropenia, meaning white cell very low, or patient who is undergoing chemotherapy at that time with anticipation that the count will drop. And also in hematological cancer patients, the platelet is low, so they may prone to bleeding. So with injection generally is intramuscular, so that should have some caution. Not that you can't, but perhaps you need to be a little bit more careful. So I think overall, because of risk of the severe COVID infection is very high with high mortality, as what we can see from other countries' publication, perhaps I think patients with hematological cancer patients should get vaccination, but with a few criteria or discussion with the treating physicians. That would be my take. The timing of vaccination, I think maybe I let Ho speak on solid tumor first before we talk about timing of vaccination.
Okay, just looking through the questions. So we can only speak in general term, cannot speak about individual patient circumstance. So for those patients who have completed surgery or chemotherapy and those who are on hormones, we don't think that is a contraindication. So hormonal treatment is not a contraindication. For those who have completed chemotherapy recently, so let's say 2-3 months ago, then the immune system is totally back to normal. So there is no issue there as well. The difficulty would be those who are on chemotherapy. What is a good time to have it? That one is actually a bit more difficult to answer. Depends on what type of chemo and what line of chemo, because if you have many lines of chemo, the immune system tend to be more affected, and the blood counts and the condition. So I think that one you probably have to speak to the treating physician. It has to be individualized. As a rule of thumb, hematological patients are more vulnerable than patients with solid cancer. And some chemo, like chemo for sarcoma or chemo for breast cancer, tend to be more myelosuppressive than chemo for, let's say, colon cancer. I cannot really give a very generic answer, a specific answer for your questions. Patients on targeted therapy, let's say Tagrisso, that one we don't think it is a contraindication, although the data is very scarce. But targeted therapy per se, I mean the molecular, small molecule targeted therapy shouldn't be a contraindication.
So there are a lot of questions from a lot of patients there about even targeted therapies like trastuzumab. They have to be on it for a year. So is that contraindication?
Including trastuzumab, that's not a contraindication.
Yes. Okay.
So
good.
If I can jump in there, and I agree with both Jinjin and Go on all that's been said. Right now, I think the one absolute contraindication, which means you shouldn't be vaccinated at all, is if you have a history of an anaphylactic reaction, meaning if you take penicillin and then you swell up and your blood pressure drops and you have trouble breathing, or you take seafood and this is the reaction that you get. So those people should not take the Pfizer or the Mrna vaccine, because there's something within that molecule that I showed, the vehicle that carries the active component of the vaccine is the one responsible for causing this anaphylaxis. But all the other types of vaccine, the inactivated vaccine, the Johnson & Johnson, if and when we get it, will be suitable for those who don't have anaphylaxis. So right now, it's mostly for the mRNA Pfizer vaccine.
So thank you for about comment, because we are going to also discuss this about, is it safe to give it to immunocompromised? What type of vaccine would be safe for someone who is immunosuppressed? So that's one question. And with regards to the side effects, maybe, when people, a lot of people are on other drugs like Celebrex, they have allergies. They're allergic to seafood, but they never had an anaphylactic shock before.
Yeah.
So are they contraindicated? So maybe you and Sagunan can discuss this. Thanks.
So perhaps in terms of the safety, when we talk about safety, one is of course the side effect, the anaphylaxis, and two is when we use live vaccines, and Sagunan has already listed the types of live vaccine, the typhoid vaccine, the oral polio vaccine are examples of live vaccines. Those are the ones you cannot give to people who are immunosuppressed. So thus far, none of the vaccines that are going to go onto the market are live vaccines. So I think in terms of the issue of safety, other than anaphylaxis and live vaccine, I think even people who are immunosuppressed, whether you're on cancer chemotherapy or you're on all those other things that have been discussed this morning, it's fine. So what is a concern is that those of you who are immunosuppressed for whatever reason will not be able to mount, like what Guna said earlier, as good an immune response as those of us who do not have cancer or who are not on chemotherapy. So I think we should be really, really clear that most people should be able to take all of the types of vaccines, including patients with cancer and undergoing chemotherapy. The question, as Jinjin says, is when should they be vaccinated? And even with other vaccines, let alone the COVID vaccine, you wouldn't vaccinate someone who's actively unwell, who is neutropenic from chemotherapy, who has, and even if you have a mild virus from another infection, dengue or something, that is not the time to vaccinate. That is just normal practice with vaccination. And of course, this needs to be followed with the COVID-19 vaccine. The question around if you have mild allergies, mild to moderate allergies that doesn't tantamount to an anaphylaxis reaction, you can still take you can still opt to go for the Pfizer vaccine. there's a there's a rule that people should be watched for 30 minutes, Farida, yeah, in case they develop reaction. And as I said, millions of people have been vaccinated without too much hassle. Obviously, in the early phases of the rollout, there were all these concerns, but now that we know what to watch out for, it should be much safer.
So, Prof. Adiba, you mentioned this rate of 4.7, is it, per million doses anaphylactic shock. So, how do you compare that with, let's say, penicillin?
So I think
usual
penicillin
antibiotics that
allergy
we
is
give?
much more frequent.
Is it
And I don't
something
have
of a
the
low number?
numbers off the top of my head, but Farida is nodding, Guna is nodding. I think it's much more frequent than that. You may have numbers better.
Well, I looked it up lah. So it's about 200 to 400 anaphylaxis per million dose.
Well, there you go.
So it seems that these vaccines are quite safe, right?
Yes.
Yeah. And the type of vaccines is also not so important here in terms of safety for our cancer patients, right? So there's no live vaccines being used.
No, none of the ones that I showed you are live vaccines.
Yeah. Okay, fantastic. So maybe some comments from Prof. Ho, because I think there's still some questions about the, like types of treatment, timing. I think Ganjiji, you wanted to say something about timing just now. Do you want to elaborate?
Yeah, I would talk about timing. I think a lot of people also in the questions section, I can see quite a number of questions about not just timing, as well as some of the drugs like steroid, okay? Because that is also immunocompromised. It reduces our immune system in a way. So the timing, obviously, like what Prof. Adiba has mentioned, if patient is because of hematological cancer, the chemotherapy generally will reduce the white cell as well as the platelet. So patient can get any form of infection during those period of time. So to give a vaccination during that time may not be the most appropriate timing. So from what I have read from the international guideline is that you do not give during when patient is going to have chemotherapy that is going to cause a low immune system. Not just because you may have other complications that can arise. The other thing is also the immune response may not be what we really want. If you have listened to what Prof. Sagunan have eloquently presented, we really need our immune cells, our B cells, and also our T cells to help us to mount that immune response after vaccination. If our count is low, then we may not have sufficient B cells to mount the response that we really want, okay? So in general rule, it would be that you want your B cells at least to have recover so that whatever vaccine that you have been given, then there will be some form of immune response so that you will then generate an antibody against the COVID-19 infection. So it is not that it is not unsafe to give, but it's just that you want to maximize the antibody response when you give the vaccine. So that's why the timing.
Okay, thanks, Gigi. I think, Praho, you mentioned about a new study just now, right? So that study that you presented about the immune response, were that in a population of immunocompetent or compromised cancer? What sort of patients were in that study? Were they really immunosuppressed or not?
Yeah, they are very immunosuppressed. Half of them are on high-dose steroid. I think 1/3 are on some kind of chemotherapy or targeted therapy. But in the small cohort, there's only one patient on immunotherapy. He did well. He survived the COVID infection and mounted immune response. So to answer the question about patient on immunotherapy, the one actually there's not a lot of data. So, but I think in general, we do not think it is a contraindication for vaccination. So immunotherapy should be considered not a contraindication. The targeted therapy, Tagrisso, bevacizumab, trastuzumab, those are usually considered quite safe.
Okay.
I think, Aisha, I need to mention immunotherapy comes in many different types of immunotherapy. So we have to be a little bit clearer for our public as well. So some of the immunotherapy, which is like anti-CD20, right, rituximab, I think Prof. Guna would agree with me. They are B cell depleted, and B cell is the one that will produce antibody. So I think Prof. whole study is very good, but it just mainly talking about solid tumor, have a solid tumor patients actually mount the immune response. If you were to look at his slides, the hematological cancer patient, some may not, some do worse, right? So I think it is important for us not to generalize all the immunotherapy. So patients who are on anti-B cell immunotherapy, for example, rituximab, I think Prof. Guna will agree with me that they are B cell depleted. You may not mount a very high immune response, but that doesn't mean that you should not go ahead and have vaccination. Perhaps if you can wait, then general rule maybe for your B cell to recover after the last dose of immunotherapy, maybe 3 months after that, then you will have a little bit more confidence that it will mount the desired antibody response in general. So similarly in transplantation, after transplantation, again, when I say transplantation, I'm talking about stem cell transplantation. Basically, the counts were low, the immune cells will all go down. So it takes about 3 to 6 months, especially in allogenic, meaning different donor, using not your own stem cell, but someone else's stem cell. So then again, the rule is that you want some form of recovery of the B cell to see the antibody response. And as in steroid, generally, again, it is not contraindicated. But if patient like post-transplant, they have a lot of graft versus host disease, they are on a lot of medication, again, that may not be the time for vaccine. But if they are on lower dose of steroid, whether it's prednisolone, they say general rule is less than 0.5 milligram per kilogram, then it is okay, right? But if you're on higher dose with a lot of other immunosuppressive drugs, you again may not be able to see the antibody response. And also that's the general rule. I'm not saying that you can't, but I think that should be individually discussed with your treating doctor. I think, Guna, would you agree with me?
You're muted. Sagunan cannot hear. We can't hear you. I think you're muted somehow. Okay, something technical issue. Okay, it sounds like, you know, like a lot of details are required, and to prepare for this rollout, maybe we can get Prof. Sharifah to comment a little bit about the cancer patient rollout. What should be our wants? Because I think right now the Ministry of Health, they're trying to, you know, quickly get this through. Maybe we should give feedback to them, you know, like how you think from the discussions we had, where should our patients get our vaccines?
Very good question. So I think, so when we first had a meeting, they asked us for a line list of all our frontliners. They also asked for the number of patients in our hospital with chronic illnesses, including cancer patients. So, you know, I think that's more of just to get the numbers, just to have an idea how many patients are we looking at who should be in that phase 2. But it hasn't really moved on since then. You know, there's really no details yet on our side. Maybe they're preparing on their side, but there's no details from our side in terms of, you know, patients who already have appointments or are under follow-up in hospitals, who are vulnerable. You know, it doesn't make sense for them to go to these big day ones. That's probably better for the phase 3. But saying that, in order to reach out as many people as possible, you know, the hypertensive who are quite well, the over 60s who are very fit, they don't have any chronic illnesses, they can easily go to these places. But there should be a mechanism where two can run concurrently. So one is that having these mass places so that as many people can go in, can register. So what I heard from my strategy is that when you register, you can actually choose where you want to have your vaccination done. So that was a plan. I don't think they've done the nitty-gritty detailing of that yet. So that's just one way of registering. Whether they are going to allow for other ways of registering, whether they're going to say, okay, hospitals can stock up on the vaccines and you can vaccinate your patients accordingly. You know, you have your own schedule, you have your own place and whatnot. We'll give you 500 vaccines this week, schedule your patients. So we haven't got those kind of details. I think they're still trying to see which model fits best. But for sure, for the phase 3, for the rollout, they are going to do it big scale because they need to vaccinate a lot of people in a short period of time.
Okay, thanks a lot. I think, you know, like what Dr. Sylvia mentioned earlier, I mean, not all, I mean, cancer patients, they're all very different. Some are well, they've had treatments 10 years ago, some are having active treatments, and some are actually at home. There are carers who have to take care of our advanced cancer patients at home. So, Sylvia, do you want to share some resources for them? I mean, because, I mean, vaccination, you know, home vaccination is another issue altogether, Dr. Sharifah. I think maybe that's something you want to bring up to the task force, you know, like what to do for those who are not able to, you know, like these are like care home patients, people in the care homes, the very elderly who cannot go anywhere. Can the vaccines be brought to them? Okay, so that's maybe a want, which is not easy to roll out. But Sylvia, can you share with us the resources?
I think we can also use our GPs as well, you know, in certain cases. I mean, there's a lot of avenues, but we also need to bear in mind the vaccine that we're going to use. Obviously, the Pfizer vaccine is so sensitive. So the area where you're going to have even in UM, we're thinking of having a few sites, but then when we knew how fragile the vaccine is, we thought it would probably be better just to have one site so that we won't compromise the quality of the vaccine. But once the other vaccines come in, maybe that would be more suitable for other areas as well. Yeah.
Okay. Was that you, Testing, from Guna?
Yes.
Yeah,
Can you hear me?
comment something. Yeah, sure.
No, it's okay. I was trying to answer. So just a very small thing about, I completely agree with what Prof. Gunn said, in that in rheumatology, many of the drugs that we use are also used in oncology, or rather some drugs used in oncology are used in rheumatology. And an example is rituximab. So clearly, we have advised our patients, those who are on rituximab, that they should take their vaccines before they get their rituximab, both the doses. If it is after rituximab, we have to wait anywhere between 3 to 6 months. So that's one point. And for our guidelines, so far, most of the therapies, like the high dose prednisolone, the normal doses, low dose prednisolone, the treatment basically now carries on, and the patient can be vaccinated, whether it's methotrexate. Although methotrexate, we seem to have to wait for 1 week, but all other drugs, you can carry on, even leflunomide apparently. So people on these drugs, even the biologics, the anti-TNF that we use, Remicade, infliximab, adalimumab, and also drugs like tocilizumab. Patients who are on this biological DMARDs, absolutely no problem. They can go ahead and take their vaccination. So it all goes back to, as everyone has mentioned, you need to discuss with your doctor. And case to case, patient to doctor, doctor to patient communication. And interestingly, as Prof. Adiba very clearly made it out, when the issue comes with allergies, I see everyone asking about allergies. You know what? And one person actually mentioned that they had anaphylaxis to iodine injection. So anaphylaxis is not a pleasant thing. People get admitted for anaphylaxis. And then if we survive that anaphylaxis, we have to walk around for the rest of our lives with an EpiPen and a medic alert bracelet. So these are very important points. But all those other allergies, like, some people take seafood, feel, kurap or gatal, scared, and sorry for the use of that word, but, who have some form, I take this, I feel dizzy, or, there are all sorts of allergic responses that people say. And if you discuss with it and we think it's absolutely fine, then we can go ahead with the vaccination. Shouldn't be a problem. Yeah.
See, there's one question I got from the question about lymph nodes, because a lot of our cancer patients have had surgery to their lymph nodes. So they're a bit concerned about the side effect. If you read the docket, you may get enlarged lymph nodes after the vaccination, So maybe some comments from the ID team and the Rubato people, is it safe for them to get vaccinated?
Absolutely. If you get enlarged lymph nodes after you're vaccinated, that means your immune system is working very well.
Yeah,
So that is a sign that your immune system is working very well. And I think a lot of these the infodemics, the hype around the side effects of the vaccines that have been circulating in the social media and others is because there is a lot of attention being put, on these vaccines. And on top of that, the world has never seen such a massive vaccine rollout ever, 148 million doses. And each and many of these are being scrutinized. So there was a recent, message going around WhatsApp about the UK's warning, and actually if people bothered to read the whole article that the UK government posted, it says that, the side effects are no different from normal kind of vaccine programs, or the deaths and the other occurrences are no higher than a normal occurrence, whether it's a Bell's palsy or the penicillin allergy and all those things. But because there's so much hype and scrutiny, the people who want to create trouble then cherry pick the information that they want to highlight and say, oh my God, all these people are dropping dead like flies from the vaccines and so forth. But if you look at it objectively, then it's many are not related to the vaccines, but are in fact natural occurrences.
Okay, thank you. And I think there were some questions also. Maybe Prof. Adiba can answer this. If I had COVID-19, can I be vaccinated?
Yeah, I actually answered that. The answer is yes. The current recommendation is that you should still be vaccinated because we still don't know how long natural immunity from a natural infection lasts for. So I think if there is a takeaway message today that we want to give is that as many people as possible should get vaccinated as quickly as possible, because in some ways it's a race against time. This virus is, such a nasty, pesky virus that's already brought the world to its knees. And even with this vaccine, we are now getting all the different kinds of variants that some are not only more infectious, others may even, there's concern that may cause even more severe disease. So the more people who are going to be vulnerable to infection, the more this virus can mutate, the more we're going to get these variants. So we're going to be constantly playing catch up. So, get yourselves vaccinated as quickly as possible, bar those contraindications that we talked about, and the timing. If you actively getting acute leukemia chemotherapy or stem cell chemotherapy, obviously that's not the right time to be vaccinated. It's not even the right time to be vaccinated for normal other vaccines, right? So that would be my take-home message.
So okay,
for the mic, there's another question around pregnancy and lactating, although this is not the group for it, but just to quickly say that there was a difference in opinion between WHO and CDC, primarily because as Farida said, this group of people were not included in the clinical trials. And that's again normal. Companies do not include people who are pregnant and lactating in clinical trials as a kind of safety thing. But post-vaccination, post-rollout, the scrutiny, the pharmacovigilance doesn't show that people who are pregnant or lactating have any reason not to be vaccinated. And on top of that, we know that pregnant women have a risk of getting more severe disease. So in short, yes, if you're pregnant or lactating, discuss with your doctors. But if you came to me to see that vaccine, I'm going to say, get the vaccine.
Okay, I'd like to ask permission from all the panelists. Can we continue for another 10 minutes? Are you all okay? Because we're supposed to finish at 12:30, but it's 12:34.
Okay, I've got a lunch date, but yeah, sure.
Lunch date. Okay, all right. So just short 10 minutes, right? So maybe we can go back to Dr. Sylvia to share a bit about resources that's available in the community for our participants, for people who have issues about traveling to hospital and all that. Dr. Sylvia?
So in terms of being vaccinated, so far it looks as if everyone will need to travel to hospital. But just to reiterate that the palliative care guidelines are that our patients are actually particularly vulnerable and should be being vaccinated. But again, that is going to be very individual and needs discussion with their specialists. But the other aspect that always comes into discussion with patients with advanced disease is thinking about what are their priorities, what are their individual situations, what do they want to achieve, and what's really important for them. And the alternative, I suppose, for them to vaccinating is shielding, but that limits who you can be, who you can see face to face, and so that will depend very much on individual circumstances. But overall, this is the group of patients that are clinically vulnerable and need vaccination. But it does require complex conversations, looking at what the medical options are out there and how those medical options can help you achieve the goals that you want to achieve. So sort of taking it a little bit the other way around sometimes. I think we've talked a lot about the medical options, but everybody will need to take that and fit that with their own life priorities.
Okay, thank you. I think we have to recognize that, everybody is an individual and decision makings are an individual decision making. But I think maybe you have some resources on Hospice Malaysia website, right?
Yes,
for those
yes.
who require palliative care in the community.
Sure.
Tough time for everyone, I think, for them to travel to hospitals.
Yes, so our website, www.hospicemalaysia.org, has various carer resources and links to other useful information for carers and for patients.
Okay, thanks, Sylvia. Can I just get back to everybody about the public health situation we're in? So I think we mentioned, Prof. Adiba mentioned the herd immunity thing, right? And how we can reduce severe infections, reduce transmission, blah, blah, blah. But really, what do we need to get herd immunity, Prof. Adiba? How many % of the population needs to be vaccinated? Because if you look at what the tagline is for the national vaccination program is, lindung diri, lindung semua, right? So I think maybe you want to touch upon how many %, because I think a lot of people are very scared and they're still waiting to see what happens before they decide, before they want to whether get vaccinated. So maybe you can share that with us.
Farida, you might be more up to date with this. I think generally, globally, the target that people are hoping to reach is 70%. Now, do remember that currently we're not vaccinating people aged 18 and below, correct? So when you say 70%, it's 70% of the whole population. So so if you're already excluding, and I think the Malaysian population is relatively young, you're excluding 18 and below, you've already reduced that population, for the overall herd immunity. So that's why, as many people as possible, adult population should be vaccinated. So what is this herd immunity? It's that magical percentage of the population who've been vaccinated or have been naturally infected, so that that those who cannot be vaccinated for whatever reason are protected, because the virus, when you reach that certain level, the virus kind of will not propagate itself anymore. And so if you look at it on the other, conversely, like what I was saying, why we need to run this race against the virus is because if we leave, say, 70% of people unvaccinated, then the virus is going to go very merrily mutate, and and then we're going to have to keep designing new vaccines.
So I mean, it's quite interesting because I was trying to see how many percentage of non-adherence, to vaccination. So in children and maternal health, for infants and all that, it's about 20.7% non-adherence. Okay, but if you look at the the care homes and where healthcare workers are advised to vaccinate against flu and all that, the uptake is only about 40%. Care workers as well as the people in these care homes get vaccinated. So it's very low, right? And then and you look at the people going for Umrah, because Umrah, 100% of people will be asked to do the meningococcal vaccination, but flu vaccine and pneumococcal.
Aisha, you're dropping in and out a bit.
2018. So, am I breaking up?
Yeah.
Sorry. So I think the recent numbers show very low voluntary vaccination rate. So I think this by here we need to reiterate that you need that herd immunity to protect the vulnerable ones, isn't it? So how else can we improve this uptake of vaccination? I mean, it's just an open question to everybody.
It's nice and romantic to think that people will do something to protect others, but I think in the long run, people will be vaccinated because they want to protect themselves. And so I think we as a medical community need to work to convince not just our patients and the community at large there that then they should be vaccinated, that overall these vaccines are safe and very, very effective. The risk of getting severe COVID is much higher than, like what Guna and Farida said earlier, than the risk of getting the severe anaphylaxis reaction, which in the scheme of things is the thing that we should fear most.
Okay. So, now we go around table because we only got like another 5 minutes. So let's go around the table and tell us what you want from this vaccination program, each of you panelists. You want to start, Ho?
Although patients cannot choose the type of vaccine they are given, but I think for the sake of informed consent, they should be told what vaccine it is. It's important for us to know what vaccine we are receiving. So that is my main concern. I want to say something about the lymph nodes, patients with lymph nodes.
You need to repeat that, Paul, because you were breaking up.
Oh, sorry. About the choice, about informed consent when having vaccine. I think when we get vaccinated, we should be told what vaccine it is. It is part of the informed consent. We need to know whether it's attenuated vaccine or is it RNA or DNA vaccine. Then we can decide whether we want to have it or not, rather than we are blindly given one. I want to touch on the lymphadenectomy patients. If you have, let's say, breast cancer on the left side, you can have the vaccine on the right side. If you can't have the injection on both arms, you can still have it in the thigh. There was one question about afatinib. Afatinib is a small molecule targeted therapy, so that should be considered not a contraindication.
Okay, let's go around the room. Who wants to go next? Go ahead. Guna, you're not muted. Please go ahead.
Oh, okay.
Yeah, your wants. What do you want the national program to be like? Like what do you want?
Well, I think with all the criticisms ongoing, and I think so far we have to compliment and commend all the efforts that are being done. My only complaint is, why is it taking so long? I think that's what we see, WhatsApp chats and all that. But I think let's put that behind and focus on getting the job done. And I think this is the time for everybody to, let's make it easy for the authorities. Now, the vaccine has arrived. There's a very good plan. And let's just follow the leaders. We have fantastic leaders. We have Prof. Adiba here is with us. And we have great teams working 24/7. I personally know some friends up in Putrajaya, and I can tell you they're having sleepless nights. And they're doing this for the Malaysian people. And the best thing we can do right now is to show them our support. We have questions. You must have these questions. I see many questions, and we must have this conversation. That's why doctors are here for you. We are here to discuss with you. And the end result is we want you to be safe. We want you to be able to continue to live productive lives, which is why you're on therapy in the first place. So let's take this challenge as a doctor-patient relationship building test. And let's hope that everybody can get their vaccines. And let's deal with COVID-19 once and for all. And this is the opportunity. Thank you.
Okay, thanks. Prof. Gan?
Yeah. My one, I think what Prof. Ho mentioned is very important. I think we should be able to choose which vaccine we want. Some may be a bit hesitant on the novel technology for whatever reason, but it's also boils down to the availability and how soon we can get the vaccine. And the other one that I want, or I think everyone tend to forget, is that the caregiver of cancer patients. If you see the second phase is for cancer patients as well as high-risk patients, but some of the cancer patients may not be able to have the vaccine for whatever reason, because they are undergoing chemotherapy, undergoing stem cell transplantation, for example. The caregiver ought to be also in the priority list, because they are the one who is going to be looking after the patients. If they do get infection, then that also means bad news to the patient. So I think perhaps people tend to forget about caregiver. I think caregiver is also important for us to look into. I think that perhaps is my want, besides what Prof. Ho mentioned, that we should be given the choice which type of vaccine we want, because maybe we have whatever reasons we are more comfortable with one or the other. But I think that may not be feasible in this time when we may not be having it available. So I think that's my want in that sense. Thank you.
Okay, thanks, Jinjin. Dr. Sylvia, last words. What are your
Okay. So Prof. Adiba mentioned that most people are looking from an individual perspective, but I suppose my hope is that we will also look at the altruistic view, that people will take up this vaccine, because that's going to be the way out of the pandemic. And that's really what's going to make a difference to the quality of life of our patients. That they'll be able to access care easily again. And we have to think of the sort of wider toll this pandemic has taken. So yeah, my hope is that people will take up the vaccine as much as possible. Of course, everyone has concerns, and it's important that we answer those concerns and look at them and take them seriously. But it's not just for ourselves, it is actually for the community as a whole. That's my wish.
Thank you. Sharifa?
Just a word on whether you will know what vaccine you receive. You will. At the moment, you may not be able to choose because it depends on which vaccine we receive. So the first group is obviously Pfizer, and I think the majority of the vaccines that we have contracted to receive is going to be the Pfizer. But that along the pipeline, there is some agreement with the AstraZeneca, with some of the China vaccines, and also the Russian vaccine. So Whether it's going to be like, okay, which vaccine would you like? I'm not sure. But I think for the, yeah, exactly. Because the numbers are so limited. Even the UK had to delay the second dose because they wanted as many people to get the first dose. So that's also another contentious whether it's the right thing to do or not. But for Malaysia, we are now making sure that for the Pfizer vaccine, you get the first dose and you get your second dose within 3 weeks. You know, that 3 weeks stipulated. They don't want to vaccinate as many people as possible and then just wait for the next shipment to come back and then give you the second dose. So consent is there. It's a written consent. You will be told what vaccines you're going to get, and your MySejahtera is supposed to be a magic, like a passport thing. So once you've completed it, you get a certificate. I have completed, and it tells you which vaccine you received, which batch, and so on, because there are those fancy QR codes and whatnot. So consent form will be there. And I just like to echo what Sylvia has said, Adiba, and everyone here. Yes, I think there's a lot out there. Social media has its pros and cons, and be very selective what you read. Hopefully, you know, even though you primarily people want to protect themselves, but hopefully some of the message will come out that when you enter a vaccination program, it's not just about you. It's about the whole community and the whole country.
Yeah, Farida, and so I want to say that you just commented on the University of WhatsApp.
Yeah. Okay, I'm going to leave for Adiba to have the last say.
Thanks, Aisha. I thought you said we only had 10 minutes. So, okay, I'll make it very short. I agree with what everyone has said. And of course, you know, the vaccination, like everything else, shouldn't be made mandatory, because someone's commented on whether it should be made mandatory. Much as we want, you know, 100% of people to be vaccinated, I'm into personal choice, but it's hope that it's educated personal choice. But on that note, yeah, I totally agree that they should be told, and Farida has reassured everyone about this. The only thing is because of the logistics, and if you are called up for the Pfizer vaccine and then you say, no, thank you, you are going to, I want to wait for another vaccine, you are going to go way back down the, you know, the 17th million vaccinees. So think very, very carefully before you reject. I haven't got shares in Pfizer or anything at all, but I just want people to get vaccinated as quickly as possible, bar the contraindications and side effects that we talked about this morning. So please, if we all want to start living normal lives again, you know, this is one part of it. Get yourselves vaccinated.
Okay, thank you all panelists. So I think we are really running short of time, but I thought I'll just summarize to 3 major points. So I think during this panel discussion, we have addressed all risks, and we know that the only risk we should worry about is the anaphylactic risk. Okay. The second one, I think we have addressed the confidence in the effectiveness of the vaccines, and there are already international guidelines out there, and we're lucky in a way that we've waited for one nation to give us some data about safety and everything. So confidence should be really strong about taking the vaccines. And the last one is we have to address that we are trying to beat the pandemic, and we are supposed to, you know, work together as a community. And that is the only way to actually beat this pandemic. So with that, I think we will end the forum here. I'll pass this now to Suniza, but don't forget, please don't leave yet. We're going to have a massive photograph, because let's see, how many people do we still have here? We still have 370 participants on Zoom. We started with 500. And YouTube, I think they're still actively seeing. I have no idea how to look at the numbers. So I'll now pass this over to Suniza. Thank you very much.
Thank you.
Thank you very much for all the speakers with a very great and excellent discussion. So I hope everyone are clear and happy with the answer. And as I can conclude and highlight here, COVID-19 vaccine is safe. And please, again, as what Prof. Adiba said, should get vaccinated as soon as possible. So to close the public forum today, it is a great honor to invite Mr. Wong again to deliver his closing speech. Please welcome Mr. Wong.
Okay, thank you again. I will make it very short. I know you guys are very hungry, and I will promise you to be not more than 3.5 minutes. Okay, actually, we have, as I said earlier, we're very fortunate that we have such a rare panel of learned experts to give us reliable information on COVID-19. I would like to just only highlight some of the statement that I learned as a layman, as a cancer survivor. Now, I'm really happy to hear the consistent message to us. That is, the benefits far outweigh the inconvenience or risk of side effects. And that is a very important statement, okay? And then I'm very happy to learn from Prof. Sagunan that give us an optimistic what happened? Video. Okay, now I don't know what is stated in my warning note. Okay, who gave us an optimistic view that really the vaccine can give us quite a lengthened protection, and the safety of the breakthrough technology of mRNA vaccines. That is important. And also Prof. Adiba showed us that 148 million people has already been vaccinated. Huh?
Doses.
Yeah. Doses, not people. Okay, doses. They're still good. 140 million people.
Still a lot of people. Yeah.
Has already been applied, and that really, should really our fear of the vaccine, because in our chat group, a lot of cancer patients are saying that, oh, I don't want to do that, and let other fellas get the vaccination. Let me be the minority, enjoy from the herd immunity. Now, that is a very bad thing. Okay. I'm a bit also encouraged that Prof. Sharifa said, now the phase 2 that we are all in, now will start in April, irrespective whether phase 1 is completed or not. Now, that is very good news. So we hope that by April the 1st, whether it is April Fool's Day or not, we will have the privilege of getting our vaccination, starting our vaccination. Now that is very important, rather than waiting for the first phase to be over, okay? Now, other than a couple of categories that Prof. Ho and Prof. Gan said, I think that all these people, the minority or the rare group, please check with the doctors. And then the rest, I think, is a patriotic duty as a Malaysian to get ourselves vaccinated so that in the end, the herd immunity can be achieved, okay? All right, I think lastly, very briefly that I have 3 things to ask for your assistance. Firstly, TAC, our mission, TAC is Together Against Cancer. Our mission is really to get, access to expensive medicine, one of our mission. And some of the second liners are very expensive and efficacious. And it's very unfortunate that some of our patients, some of our members have to sacrifice part of their life because they couldn't afford all this medicine. If any one of you can really, help us to get either reliable generic or, can approach some generous pharmaceutical company, please let us know. At least we can help more people to survive longer. And secondly, now another thing is that from last year, we are very unfortunate because we have very high number of fatality rates in our membership, because of death. Now, not of COVID-19, but most likely is other comorbidities. So I would like to encourage you doctors, and also we as well, not to discourage people from going to hospital. Because why? Because a lot of people are so scared of going to hospital, thinking that they will get COVID-19. And in the end, either the cancer, deteriorated very fast, or because they all die of other comorbidities. So that That is very important. So I would plead that, please keep your hospitals as safe as possible, and encourage we as patients, if it's necessary, please go and see the doctor, all right? Or at least take the doctor's telephone number and call him or leave a text message to him or her to help you out. Okay, the last statement I want to make is that I am encouraged that so many people join us, and I want to plead to you all that those people who are not member of TAC or Together Against Cancer or Prostate Cancer Society Malaysia, please join us. Now, the membership of TAC is the cheapest you ever think of. It's only 20 ringgit for life. Can you beat that? Okay. Now, PCSM, which is a bit restrictive, is only prostate cancer patients only. And for TAC, please contact CS Kong or me. And for PCSM, you can contact Stephen Kong, who is one of the guys who are working very hard on the technical issue for this forum. And you can contact either one of us, or just, go to our Facebooks. That will do. Okay, lastly, if all of you can unmute yourself, on behalf of everyone, I would like to thank Prof. Aisha and her team again for organizing this fantastic forum with a record number turnout, and all the speakers and who have spent their precious time and energy preparing this valuable information that I think some of us can be life-changing, because a lot of us, I know the cancer patient, have a lot of hesitant of getting ourselves vaccinated. Now, is everybody unmute yourself? Can I ask for you all to give them a thunderous applause in appreciation for what we heard this morning? Thank you very much.
Thank you very much, Mr. Wong, for such inspiring and encouraging speech. Ladies and gentlemen, here we are at the end of our public forum. We hope it was most insightful, interesting, and we'd like to thank our panel of speakers for being part of our public forum for today, to share their knowledge in their respective fields and with regards to COVID-19 vaccination in cancer patients. Our public forum would not have been success without the presence of all of you. We thank you for your valuable contribution and active participation throughout the public forum. We would like also to thank all Secretariat, who is our hardworking research assistant, and Mr. Wong and Mr. Kong from TAC and Prostate Cancer Society Malaysia, and Visibility team of Faculty of Medicine for their dedication and hard work to ensuring that our public forum today is a success. With that, I thank you. Take care, everyone, and stay safe.
Thank you very much, all of you. Thank you.
Bye.
Have a good day.
Take a photo, everybody put on your videos, and then we should do a screenshot.
Yeah. Can you put on a video so that we can put it on the Facebook? You just click your video on so that I can see your face. All of them are shy, I think.
Okay.
I got their names, but I went through all 500 of them. Yeah, I got 500 of them, but unfortunately,
allow them to unvideo them. Allow them to open their videos. Is it possible?
Okay. Fantastic.
Wow.
Okay, wait.
See how powerful the host is.
Wow, the host is powerful. Wait. Don't go away. I'm now going to page 2. Your photograph will appear in our Facebook. Now I'm phase 3. There are 9 pages, huh? Page 3. Okay, page 4, wait. Oh, page 4, I can't get any. Wait, now my. Page 5 also no. 6.
Wow, we have 9 pages. I think this is the
Yeah.
first time I've been in a group with 9 pages.
We have more. We have 13 pages when it was full house. 13 or 15 pages. Yeah.
Okay.
Yeah.
Okay.
All
So I
right.
think it's fantastic, isn't it? I hope that everybody stays safe.
Okay,
And
we finish it.
are we
Yes.
done, Mr. Wong? Yeah.
Yes, done. Habis.
Okay.
All
Thank
right,
you very
thanks a lot.
much for
Thank
your
you.
time on the Sunday.
Okay,
Stay
bye
safe
everyone.
Stay safe.
and
Thank
get
you.
vaccinated.
Thank you.
Yeah.
Thank you.
Bye.